about something other than COVID-19. So my goals today is to talk about the translational targets for asthma therapeutics. I'm Ray Panettieri. I'm Vice Chancellor of Translational Medicine and Science at the Rutgers Biomedical Health Sciences group at Rutgers University. I'm a smooth muscle biologist, have done a lot of work in the space of irreversible airflow obstruction. And today, we're going to be talking about that nexus between airway remodeling, or thought to be airway remodeling, and irreversible airflow obstruction. And at the end, we're going to talk a little bit about steroids and an exciting new work. We published a couple of papers in the last several months talking about the non-genomic effects of budesonide. So let's get started. Again, I'm really thrilled to be able to present to my friends out on the West Coast. These are my disclosures, none of which should impact on this conversation. Now, we're very familiar with the definition of asthma. Asthma is a syndrome, right? I don't have to tell you all, you recognize this quite well. It is really bronchospasm, airway hyperresponsiveness, and inflammation. Now, early times, we thought that asthma was completely reversible. What we know is as much as 10 or 15% of the asthma population develops irreversible airflow obstruction. Now, caution here, irreversible airflow obstruction doesn't necessarily mean that that's forever. And that's going to be one of the take-home messages that I'll be talking about today. So, asthma is a syndrome. These are the definitions. And in some patients, the airway inflammation may evoke a phenotype of irreversible airflow obstruction. Now, how does one get to airway remodeling? Well, this was work that we had presented many, many years ago as a conceptual model. We know that asthma is a paradigm. It's a true paradigm of gene-environment interactions. The gene-environment interactions induce asthma, and the vast majority of asthmatics will then sustain repetitive injury, either due to viruses, toxicants, or bacteria. And these injuries, as well as allergens, then induce an exacerbation. Now, the vast majority of these patients, and our patients with asthma, actually reverse that injury repair response and pretty much live a normal life with relatively normal and preserved airflow. But there's a group of patients which we believe is determined by a second genetic predisposition to an aberrant injury repair response, not a unique injury, but a response that's different than others with the disease. And this may cause a variety of remodeling lesions. Some may develop more airway smooth muscle, an increase in mass, that's more cells, larger cells, matrix deposition, angiogenesis, and epithelial and goblet cell changes in the phenotype. These things on this left side is what we consider remodeling. Now, what is the evidence that any or all of these lead to irreversible airflow obstruction? At best is an association. So here's another conceptual model, and it came from the same paper that the other model came from. We know if we look at FEV1 on the ordinate and age, most patients, not most, all patients will have a decrement in lung function over time. That's simply an inexorable loss in lung function with aging. Some of this is simply due to our recoil forces being diminished with age. Asthmatics, on the other hand, have this slope. Despite therapy, they lose function at a greater rate than normals. Now, it's not a smooth line as shown here in conventional thought. Let's consider more contemporary hypotheses. That is, every exacerbation in asthma causes a loss in lung function, which may be regained after the exacerbation, but doesn't quite come back to the same level. So this sawtooth loss in lung function associated with frequent exacerbations can induce greater loss in lung function. So what's the takeaway for the clinician or provider? At all costs, prevent exacerbations. We don't feel collectively that patients are losing lung function at a greater rate without exacerbations. Now, that's a hypothesis. It's a hypothesis that many are trying to validate, but we don't feel this is like COPD, where patients have a progressive loss in lung function over time, aside from an exacerbation-induced loss in lung function. Now, it's more complicated than even that slide. This is another conceptual model that we had published now about 6 years ago, where this is a stylized patient that you're taking care of. This is a normal patient, and you can see if we look at height, age-adjusted median FEV1, everyone's FEV1 continues to climb even into adolescence. At about age 20-ish, you start to have that inexorable loss in lung function over time. So that's normal, A. B and C are really interesting. These are children who, for some reason, be it RSV, be it allergen sensitivities, have an impact in the normal development of their lung function early in life. And you can see the stylized patient B and C took major hits under the age of 5. Now, they continued to develop lung function and improve their lung function with age, but what they lost, they lost. Now, you can see in the stylized patient that the lung function rate of decline mirrors that of A and B, and A in comparison to B and C. But notice that C starts to cross the line of disability. It isn't because they had more exacerbations. It's simply what they lost young, could not regain the function, and as they age, they have that inexorable loss of lung function. This phenotype is the patient who could present de novo to your office or to my office complaining about activities of daily living are impaired. And it seemed to have come about quickly when indeed it actually happened way back when they were under the age of 5. This line shows the disability cross as you get older with a loss in lung function at age 5-ish. Now, we know that inflammation is critical in modulating airflow obstruction. You can see here in this was an 11-year-old I cared for. Patient had bronchial carcinoid, had to have a resection, but it offered an opportunity to see what this young child's airways looked like after years of inflammation. Look at the size of the subbasement membrane fibrosis. This is type 5, pardon me, type 3 collagen and fibronectin secreted by myofibroblasts. This is not basement membrane secreted by epithelium. You also see here ongoing inflammation despite therapy, tremendous amount of CD4, CD8 positive lymphocytes as well as eosinophils. And notice the close proximity to airway smooth muscle, as if the two cells are communicating. So the takeaway here is even with therapy, some mucosal inflammation can be continuing. The question is that inducing an irreversible airflow obstruction phenotype? We don't know. Now, when we talk about remodeling, we're talking about goblet cell hypertrophy, hyperplasia, more muscles, angiogenesis, more vessels, and scarring, the scarring of type 3, type 5 collagen and fibronectin. That is derived from mesenchymal cells, not epithelial cells. So what I want to now do is transition after that preliminary discussion and focus for the balance of my talk on a novel observation regarding TGF-beta and its effects in mediating an irreversible airflow obstruction phenotype. Now, the muscle is an important cell. It is the pivotal cell regulating bronchomotor tone. It contracts, it relaxes, it grows in response to growth factors. We know airway smooth muscle mass due to hyperplasia, more cells or hypertrophy occurs in most asthmatics, even mild asthmatics. Data from UCSF is shown in mild asthmatics that there's about a 40% increase in airway smooth muscle mass. But as I had shown in that last photomicrograph, these cells also communicate with trafficking immunocytes. They have cell adhesion molecules, secrete cytokines and chemokines, and secrete matrix. So this cycle could actually induce a phenotype of irreversible airflow obstruction. So what I'm going to do is talk about TGF-beta. Now, TGF-beta is a growth factor or cytokine found in fibrotic disease, and it's been associated with asthma, especially severe asthma, when we've looked at those levels in bronchoalveolar lavage. So one of our models is that of the human precision cut lung slices. I just just show you a cartoon here. We get lungs about every 2 weeks. We've been doing this for about 10, 12 years now. Fill them with agar. We size them. We then core them, and we use a microtome to cut very thin slices. These thin slices are the thickness of a hair, about 300 microns, and they're about 1 millimeter in size. Now, importantly, using using microscopy, we can look at luminal diameter narrowing, and you can see here as we increase our dose of carbachol, we can almost nearly obliterate the lumen of a small airway. If we give isoprenaline or isoproterenol, we can relax that airway. Here we can show you what we're really looking at. This is a human airway, small airway, non-armored, 1 millimeter in diameter. And notice it's tethered open by parenchymal or alveoli tetherings. Now, in this case, what we did is we gave TGF-beta overnight at a dose that equals that found in lavage of asthmatics. And what we're looking at is the percent luminal diameter narrowing. And what we find is overnight exposure to TGF-beta narrows the luminal diameter substantially, almost 20%. Now, this 18-hour exposure has absolutely no effect on growth of cells or on matrix deposition. We've looked at that in several publications, and we don't see an enhancement in that case. However, given that at baseline TGF-beta causes narrowing, looking here in response to carbachol, and this is basically a PC20 in our Petri dish. These are all human lung slices. You can see that carbachol causes constriction. However, TGF-beta shifts the curve to the left, and especially at the lowest doses of carbachol, you see a dramatic increase in the bronchial, in the luminal diameter. Now, it flattens at the maximum because you don't get any greater than 75%. But in this place, you're clearly seeing an enhanced EC25 as well as an EC50 to carbachol. So what does this mean? This means TGF-beta induces airway hyperresponsiveness by itself. Now, how might this work? Well, TGF-beta can bind to the cognate receptor, the TGF-beta 1 and 2 receptor, activating and phosphorylating SMAD. SMAD can then affect gene expression, and it can actually modulate the expression of a variety of signaling molecules that are shown here, relevant to airway smooth muscle contraction. On this side, we show how airway smooth muscle contracts. Acetylcholine binds to a G protein coupled receptor. This would be the M3 receptor. M3 receptor causes IP3-induced calcium release and activation of myosin light chain kinase and contraction of airway smooth muscle. Now, what you may not know is in parallel, there's another pathway that activates RhoA and then RHO kinase. This RHO kinase phosphorylates the light chain that would relax the muscle. So what happens when you give carbachol is not only do you get a pro-contractile response, you actually inhibit the relaxation that occurs normally in response to these therapies. So what we're now going to look at is how does TGF-beta affect these two pathways? Does it affect calcium? Does, through reactive oxygen species, modulate contraction, or through P38-ERK? So, if we give TGF-beta by itself to airway smooth muscle and look at calcium signals, here is in response to carbachol, and we're looking specifically at this pathway, the calcium mobilization pathway. Notice that carbachol causes a big increase in calcium, calcium being essential for contraction. But notice that TGF-beta has virtually no effect on mobilizing calcium. So in this case, we know the acute effects on calcium is nil. So that one contraction of the luminal diameter that happens at 18 hours, we don't believe it's because TGF-beta is activating calcium pathways in the muscle. Now, if we give TGF-beta for 18 hours and then give carbachol, what one can see is that you do get an enhancement of the carbachol-induced calcium when you treat overnight with TGF-beta, and that's seen here with the area under the curve. Now, curiously, histamine was not affected. So all contractile agonists don't manifest this effect, but it looks like TGF-beta uniquely enhances the calcium signal that is induced by carbachol. So the PC20 would be changed. Now you may say, well, Panettieri, when is TGF-beta liberated in the airway? It's liberated in the airway associated with exacerbations, specifically an exacerbation to viruses like rhinovirus. There's a marked increase in TGF-beta, and it's also released in response to ozone levels. So what we're suggesting here for the first time is TGF-beta can modulate excitation contraction coupling without any effects in growth or matrix deposition. Now, we then looked at its effects on RHO kinase. We showed that carbachol-induced calcium was affected, but what about RhoA and RHO kinase? So how did we go about doing that? Well, we knocked out the RhoA pathway using silencing RNA. We gave carbachol, and you can see that if we give carbachol, you get a phosphorylation of light chain. That's quite impressive, but also look at the carbachol-induced phosphorylation of light chain. This is the very last step in contraction of airway smooth muscle. Now, when we knock RhoA out, curiously what we find, and you can see there's no RhoA when we knock it out, is that phosphorylation of light chain is not affected. So, curiously, TGF-beta is not having an effect on this pathway, but it does phosphorylate light chain. And that's simply shown here. If we look at phosphorylation over total, the higher number means more contraction. You see TGF-beta. In that instance, anytime TGF-beta is present, you get an enhancement of phosphorylation of light chain. That means more contraction. when you knock it down, you can knock down the carbachol-induced effects, but you don't eliminate the TGF-beta-induced effects. So we ruled out RhoA as playing a role. So what about SMADs? Is the TGF-beta signal requiring phosphorylation of SMAD? Well, here we give TGF-beta, and you can see SMAD3 is phosphorylated robustly. The dual treatment also, you can see TGF-beta phosphorylates it in this instance, and you get an enhanced phosphorylation over TGF-beta. Now, when we knock this down, look what happens. In this instance, the carbachol-induced phosphorylation of light chain is maintained. That's shown here. But the TGF-beta signal is completely eliminated. That's shown here, looking at the collective data. Carbachol and SMADs, you can see that this is dramatically, the TGF-beta effects are dramatically diminished when we take out SMAD3. Now, if we take out SMAD2, I won't go through the blot here, but just focus. We know that SMAD2 is not mediating this effect. So even though SMAD2 is phosphorylated in the presence of TGF-beta, what we know is this signal of excitation contraction coupling is not dependent on SMAD phosphorylation. So what we've now done is we've looked at this pathway, we've looked at this pathway. We'd like to look now at ROC and see if that is occurring. And that we are still undergoing those experiments, but the takeaway at this point is TGF-beta alone causes narrowing of the luminal diameter, especially what we think after a viral infection or ozone. TGF-beta by itself, not because of remodeling. And it amplifies carbachol, but not histamine. It enhances a calcium signal, and it does not appear to require RhoA, does require SMAD3. Now, I want to transition to another theme because I showed you hyperresponsiveness, but can TGF-beta render airway smooth muscle insensitive to a beta agonist? And you know why that matters? Because you in the field and me see patients who are unresponsive to a beta agonist. Ergo, irreversible airflow obstruction. So let's look at how beta agonists work. The beta-2 adrenergic receptor is coupled to GS. GS activates adenyl cyclase to generate cyclic AMP. Cyclic AMP activates protein kinase A. And the reason beta agonists are so effective is once pKa is activated, it can modulate a variety of downstream signaling effects in airway smooth muscle that cause relaxation. So how does TGF-beta interface here? Well, in this set of experiments, we did the following. We gave either isoprenolone or isoproterenol. That could be formoterol, it could be salmeterol, it doesn't matter. Or we give prostaglandin E2. Now, PGE2 binds to an EP receptor separate from a beta-2 adrenergic receptor, but it too is coupled to GS and activates cyclic AMP. So we're looking here at cyclic AMP as determined by an ELISA. In the presence of isoproterenol, we get a huge increase. This, by the way, is about 3,000-fold increase. But look what happens when TGF-beta is given overnight. Almost halving of the amount of cyclic AMP, almost half of the amount of cyclic AMP that is generated by airway smooth muscle. So TGF-beta diminishes beta-2 adrenergic receptor-mediated cyclic AMP. Look at PGE2. PGE2 is equally effective in increasing cyclic AMP, but through a different receptor. Indeed, TGF-beta dramatically decreases the ability to increase cyclic AMP. So not only does it cause airway hyperresponsiveness, but it makes beta agonists be less effective. So how might this work? Well, again, we looked at the cyclic AMP that's profoundly diminished here. And we did the following set of experiments. What we found is a dramatic increase in PDE4D expression. I didn't have the immunoblot here to show you, but this is all published work. What we found is when you give TGF-beta, phosphodiesterase 4D is remarkably increased. Now, why is that important? Phosphodiesterases break down cyclic AMP. So we looked at gene expression, and you can see when we give TGF-beta, we get a 5-fold increase in PDE4D expression. It is increasing the enzyme that degrades cyclic AMP. Now, if we use a TGF-beta blocking receptor antagonist, look at that. You knock it down remarkably. So the TGF-beta receptor is necessary. Now, if we take out SMAD3, look what happens. Markedly decrease. So TGF-beta induces phosphodiesterase gene expression that is SMAD2 and SMAD3 dependent. If you have higher phosphodiesterases in the airways, you're going to decrease the amount of cyclic AMP generated by human airway smooth muscle. So what we've shown is that TGF-beta can enhance contractile responses, no doubt about that, in response to carbachol, but importantly, it inhibits beta agonist induced cyclic AMP levels by increasing phosphodiesterase 4D expression. So the concept through SMAD3 and SMAD2 phosphorylation, TGF-beta modulates both limbs of this signaling. This is important because after an exacerbation, typically, not allergen, but viral or toxicant, we see a sustained phenotype of airflow obstruction, potentially with beta agonists not working. Could this be mediated through TGF-beta's effects directly on airway smooth muscle signaling? So TGF-beta is a novel target to reduce airway hyperresponsiveness. We have shown it dually modulates contractile pathways while inactivating relaxation pathways. So as we go forward, taking out TGF-beta, specifically around an exacerbation, may restore lung function and ultimately address the phenotype of irreversible airflow obstruction. So we've gone through a lot showing the interactiveness of these two pathways. What I'd like to do is also show a different approach for novel bronchodilators. In this set of work, we looked at how does the muscarinic receptor couple to PI3 kinase. This is separate and distinct from the TGF-beta, but a novel translational target. So we gave carbachol to our human airway smooth muscle cells, and we looked at a phosphoproteomic signature in the presence of carbachol. What we found is that PI3 kinase, delta and gamma, are phosphorylated robustly after giving carbachol. Now, this pathway has never been exploited as a bronchodilator, meaning if we could block this pathway, we would get bronchodilation. Now, PI3 kinase, you all are probably very familiar with this. You're familiar with the alpha beta isotype. These are very important as growth factors and in carcinogenesis, and there's actually therapies to the alpha beta PI3 kinase. What you may not be so familiar with is delta gamma. These are exclusively coupled to G protein coupled receptors, and they modulate a variety of functions in many, many cells. However, this one is not going to have the myriad side effects of giving an alpha beta PI3 kinase inhibitor. Airway smooth muscle express alpha beta and delta, but not gamma. Now, in our model, we wanted to look at contraction of airway smooth muscle. And we used 96 wells. These are airway smooth muscle plated, and then contraction occurs. And if we give something like bradykinin, this Maltese cross becomes narrower, showing that we get constriction. However, if we give formoterol, a beta agonist, we get robust bronchodilation. That is, we restore the cross back to this baseline. But curiously, a Cal-101 compound which selectively blocks the delta isoform also knocks down contraction. And we can see it's almost as effective, and statistically it is equally effective as formoterol. So what we then did is we went back to our lung slices. And what we're looking at is, are these compounds as effective a bronchodilator as formoterol? Cal-101 that is used for macular degeneration is currently an approved FDA drug for that indication, was quite effective as a bronchodilator. Bigger signal means more bronchodilator in comparison to formoterol. Here's formoterol, and at its maximum, Cal-101 is almost equally effective. So we're very excited by the fact for the first time we're showing a potential novel bronchodilatator. If we look at whether this works in the presence of tachyphylaxis, now in this example, we gave salmeterol for 18 to 24 hours, and then came back, wiped that off, gave isoprenaline, isoproterenol, or Cal-101. Here's the control. Isoproterenol works very well by causing our slices to relax. But if I pre-treat for 18 hours and desensitize the beta receptor, look what happens. You lose 80% of the ability to bronchodilate to isoprenaline. However, Cal-101 is as effective as isoprenaline or formoterol, and in the face of desensitization, it maintains the ability to bronchodilate. That's very exciting to us. So these data would suggest that this compound, if inhaled, could be equally effective to formoterol and work when you have tachyphylaxis to the beta-2 adrenergic receptor. So by what mechanism might this work? Well, you saw this before. What we have seen, and I'll show you data, is that PI3 kinase is upstream from RhoA kinase. It's the first time to be described that it actually modulates this pathway in airway smooth muscle. And as so, we didn't quite know which G protein modulated that effect. Well, let me do some homework here. Well, maybe you said, you know, Panettieri, maybe Cal-101 and LY actually increase cyclic AMP levels. Here is isoproterenol increasing cyclic AMP levels 1,500-fold. These compounds are not increasing cyclic AMP. This does not have anything to do with protein kinase A. Now, the PI3 kinase inhibitor, really interesting, has absolutely no effect on calcium. Here we're giving carbachol and looking at calcium increase. And you can see in the presence of Cal-101 or LY, there's no effect on calcium at all. So it's not causing diminished calcium. Very interesting effect. If I gave a beta agonist would drop calcium remarkably. If we look at RhoA inhibition, if we block RhoA, now, and RhoA, we believe, is right below PI3 kinase. Sure enough, formoterol, here is our control, is a bronchodilator. Rosin, a compound that inhibits RhoA, absolutely bronchodilates almost to a better degree than formoterol. So I didn't go through all the data, but it's been published in several papers now. We have linked the G alpha 12, a G protein, concomitant with G alpha Q, coupled to M3R as the critical pathway. We have now identified that RhoA sits above PI3 kinase delta, and that blocking this pathway and this pathway can serve as an effective bronchodilator that works when a beta agonist doesn't work. We're very excited by these data because as a translational target, what we've identified in human cells and human slices is a new set of bronchodilators that will work as effective as formoterol, but more effective in a pro-inflammatory environment when the beta-2 adrenergic receptor is attenuated. So let me finish my talk, and that's a lot of signaling early in the morning. My apologies. Coffee was definitely necessary. I want to show you some data which is really thrilling. These data were published just recently in 2 papers, one FASEB journal, the other, the Red Journal, the American Journal of Respiratory and Cell Molecular Biology, in the January and February issues, respectively. We know that there is a non-genomic effect of steroids. We've heard this over and over. The McKenzie test, which is a test to look at potency of topical steroids, which is a vasodilation of rabbit ears in response to a steroid, topical steroid, has been used for years as a biometric test of potency. We don't know if such works in asthma. Yet we do know smart therapy, the use of budesonide and formoterol, actually can be used as a bronchodilator. And in Europe, Symbicort and drugs like that are commonly used as rescue therapy. So in conjunction with Chapman University and my colleague Ren Ostrom there, he has adopted an assay that is ultra sensitive to cyclic AMP generation. Using this, he can look at also compartmentalization of cyclic AMP levels. Now, a lower signal means more cyclic AMP. And what you're looking at here is human airway smooth muscle stimulated with formoterol. And you can see in a dose-dependent manner, you get a profound increase in cyclic AMP by extinguishing the floor to which the assay is bound. So this is very important assay that is ultra sensitive, probably about 100 to 500 times more sensitive than a typical cyclic AMP assay. So what we did is we gave budesonide and formoterol simultaneously. And we looked at the fold change in cyclic AMP. Now, budesonide is given at the same time as formoterol, not pre-treated. There is no way budesonide's affecting a genomic signature since it's simultaneous, and we're looking at responses within 10 minutes. Here is vehicle. You can see that formoterol increases cyclic AMP. That's not a surprise. But look what happens when you give budesonide at the same time. A massive increase in cyclic AMP with the concomitant use of budesonide and formoterol. Now, if we change our doses of budesonide, now ranging from 100 nanomolar to 1 micromolar. Look at the amplified increase in cyclic AMP when budesonide formoterol are given simultaneously with a budesonide at 100 nanomolar, 1 micromolar, or 10 micromolar in the presence of 1 nanomolar formoterol. So these data are really exciting to us because this means when we give a steroid and a LABA at the same time, we are massively increasing cyclic AMP at the level of the airway smooth muscle. So does budesonide alone cause bronchodilation? Well, when we gave budesonide alone, what we were shocked with this ultra-sensitive assay, we actually do increase. Now, the lower number is an increase. Keep that in mind. As we increase the budesonide dose, we get an increase in cyclic AMP levels that equals that nearly of forskolin. This is the first data ever that budesonide can increase cyclic AMP without a beta agonist. However, it is not adequate to bronchodilate by itself. So what I'm talking about is that budesonide by itself has no effect on the lung slice bronchodilation, but in the presence of formoterol, it does. But when you combine the two, you get a remarkable bronchodilation. Here you can see budesonide by itself had little effect. Formoterol induced it, just as I showed in that previous slide. When you add the two together, you get a marked improvement. Well, does this also work for PGE2? Here we're using a PGE2 agonist. And you can see in the presence of budesonide, anything coupled to cyclic AMP is enhanced, shifting the curve to the left. Simultaneous budesonide administration augments, look at the increase in bronchodilation in response to PGE2. We see the same response to formoterol. So can it also activate an independent receptor pathway? What we find is, interestingly, it requires a receptor. Forskolin, which activates for adenyl cyclase directly, does not get a marked enhancement in the presence of budesonide. These were not significantly different. So budesonide given with any GPCR that bronchodilates acutely increases bronchodilation. This is assuredly a non-genomic effect. Our assays are looking at 10 and 15 minutes of budesonide. Budesonide can increase cyclic AMP, but by itself is not a bronchodilate. So in summary, we're excited that we may have a molecular mechanism by which budesonide and formoterol could be a better bronchodilator than formoterol alone. This could actually justify the use of a budesonide SABA or LABA as a bronchodilator. It not only works for the beta-2 adrenergic receptor, but also for the EP receptor. So we're thrilled. I was thrilled to give you this rapid talk early in the morning, cell signaling. I'm sorry, but I'm passionate about looking for new bronchodilators that work when our beta agonists don't work. Also trying to understand the nexus of airway remodeling and the phenotype that you see of irreversible airflow obstruction. I want to thank an incredibly talented crowd here who had much to do with all the data I showed. This is Edwin Yu. He's just gone to residency. He's my MD PhD student, did his PhD work in my laboratory, and is seeking a pulmonary fellowship at Mount Sinai now. He's in the front lines of the COVID illness as house officer, and he really did all the work on the PI3 kinase RhoA pathway Cindy Koziel-White, incredibly valuable, doing all the work on our human precision cut lung slices. Everyone, thank you so much. Really appreciated your morning with you, and please be safe, and thank you. Happy to take any questions you might have.
If there are no other questions, this is Ali Chow. I'm one of the senior fellows. Can you hear me?
Yes, I can, loud and clear. Hi, Alice.
Okay. Hi. Thank you so much for coming this morning. I did have a question about the PI3K and RhoA, because there was a paper about, I believe it was Numeralisib, which is a PI3K delta inhibitor back in 2018, right?
Yep.
And they didn't have any good results. And I just wanted to see what your opinion on that was.
Yeah, you know, some of these are more potent than others. And in our hands, the Cal-101 is quite potent. There's several companies working in this space. There's also a group that are developing a delta gamma inhibitor, both of which is going to be coupled to a GPCR. Now, in our cells, though, we don't see gamma expressed. So I'm familiar with the one you mentioned. Many of the companies are coming at the angle that these are anti-inflammatories also. And so our notion is that their major effect are going to be at the level of as a bronchodilatator. You know, the pathways I described are all very pertinent for leukocyte trafficking. So the anti-inflammatory effects on chemokine receptors, which are GPCRs, I think, is by inhibiting the cytosolic motor necessary for migration. And that angle has been used for metastasis in cancer. So, you know, from my standpoint, I think we need to see more compounds coming through as inhaled compounds where we could drive the potency and the efficacy higher. But that's a great question. And keep in mind, many are coming from the angle of it being an anti-inflammatory inhibiting leukocyte migration.
So the reason I'm interested in PI3 is I actually study activated PI3 kinase and in a cell culture in B cells. I'm editing, and then they're going to be looking at EPDS patients. And so in order to find better pharmacologic studies with, to abrogate kind of that overactivated phenotype, we've been also looking at certain pharmacological inhibitors. And that actually came about to see some of this more recent research, like you're indicating, that there's some leukocyte trafficking mediators, as well as like upregulation of just inflammation in general due to PI3 maybe overactivation in this fact in asthma. Because our curiosity is also, is there any relationship to the bronchiectasis that's seen with APDS?
Oh, okay. Now I see where you're going with this. Yeah, one would wonder if this would be an effective anti-neutrophil drug, right? Because of the migratory effects, especially in chronic bronchiectasis. Did you see we're also looking at CF? Was this CF?
No, with APDS, with activated PI3 kinase delta syndrome.
Oh, okay. Okay. Gotcha.
Yeah.
Yeah. I mean, there's a lot of the companies that I mentioned are pursuing a delta gamma. I know that GSK has a delta gamma that they're looking at. So, it'll be interesting as people get more potent drugs. The first, like Cal-101, wasn't going to be used in asthma. It did have a liver toxicity signal. So, the eye drops that are used for macular degeneration is somewhat different. But the PO drug wasn't going to see the light of day. So, I think as we get panels of these drugs, it'll be interesting to see if the target's effective.
Exactly. Thank you so much.
My pleasure.
This is Matt Altman. I have a question. Great talk.
Oh,
A little bit similar to, can you hear me?
yes, yep.
Good, good. You know, the TGF-beta SMAD3 pathway is very interesting. And, you know, of course, the problem with many of these is, the pleiotropic effects throughout, multiple organ systems, with the idea of treating by an inhaled route. And to your specific point of treatment specific to the timing of an exacerbation, of course, could be very powerful. Just curious your thoughts on, really TGF-beta and more specifically SMAD3, and if there's any work in, targeting those in such an approach.
Well, there's tremendous interest in the pulmonary fibrosis community, right? I mean, the TGF-beta has been recognized as one of the potential pivotal growth factors mediating pulmonary fibrosis. So, the development of that kind of an inhibitor has been the holy grail. The problem is exactly what you mentioned, is the off-target effects. You take out a growth factor cytokine that's so critical for repair, and then you got problems, right? So, our vision in understanding this was twofold. One is to increase our awareness that you can get a phenotype of irreversibility without matrix and cell growth, that it's a direct signaling remodeling rather than a proliferative or matrix remodeling signal. And number two was the recognition that if this is a target, could we use it in and around an exacerbation as an inhaler that would restore bronchodilator response, heal the airways quicker, and then not use it as a continuous therapy. So, we have our eye on how are we going to address that. The other concept, and one of the reasons we're pursuing it using drug screening right now, is to look at the nexus of TGF-beta and how is it mediated. We know it's SMADs, but is there a very specific signal in the contractile pathway that could be modulated within the context of TGF-beta? Do you follow what I'm saying? Rather than taking out TGF-beta,
Yeah.
let's uncouple it from the EC coupling event, and that might spare it in a way that's more tolerable.
Yeah, and I guess I would just second, how important that sort of thought process is, because all of the novel therapies we have in asthma are really just preventative. We don't have any treatment for exacerbations, and steroids certainly don't mitigate the effects of remodel, many of the effects as we've all seen, and yeah, so hence really having that would be great.
Yeah, I think, you're absolutely right. I want to underscore what you all see and I see in my patients. In viral season, they don't respond to steroids. A steroid signal, giving steroids, they get better despite the steroids. It takes maybe 3-4 weeks before the airways come back, but it's relatively steroid insensitive. You see the same thing with toxicant. Now, allergen-induced exacerbations, people reverse quite quickly with steroids. So not all exacerbations are the same. And the most troublesome for me is, how do you manage a post-viral exacerbation and restore lung function quicker? Great questions. All right. Everyone's still on?
Yeah, we're still here.
All right.
This is really a great talk, great discussion. Thank you.
Oh, thank you. I want to thank you all, and best of luck as you read in the paper. New Jersey's a hot spot right now, and it's a disconcerting time on our floors. As a pulmonary critical care doc, our COVID floors, and we have 5 of them now. The respiratory illness there is astonishing. I'm probably telling you nothing that you didn't know. But right now, in a given unit on the floor, we could almost intubate all 30 patients but we selectively intubate because of the lack of ventilators. So it's a tough time for everyone. Thank you for allowing me to talk about something other than COVID. I really appreciate